الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Syphilis by Professor Mahmoud Hani Sulaiman. Tripanoma species include Tripanoma pallidum, which causes venereal syphilis, Tripanoma pallidum subspecies Pertinio, which leads to yaws, Tripanoma pallidum subspecies Endemic, which leads to endemic syphilis or Bigel, Tripanoma Keratitis, which leads to pentum. Subspecies were distinguished primarily by clinical syndromes they produce, but now lab differentiates 3 subspecies of Tripanoma pallidum by PCR. Syphilis is a systemic disease due to spirochetes. Tripanoma pallidum organism is 6 to 5 microns in length to 0.15 micron wide. Incubation period mean 21 days. Mode of transmission acquired by sexual contact. Infants acquire congenital infection by transplacental transmission of Tripanoma pallidum. These are estimated per year new cases of syphilis among adults in 1999. We see that in sub-Saharan Africans 4 million per year new cases, in North Africa and Middle East 370,000, in South and Southeast Asia 4 million, in Eastern Europe and Central Asia 100,000, in Western Europe 140,000, in North America 100,000, in Latin America 3 millions per year. Stages of syphilis, both congenital and acquired syphilis, divided into early and late stages. Early stage diagnosed within 2 years of infection, while the one which is diagnosed after 2 years is late syphilis. Within 2 years it is early, after 2 years of infection it is late syphilis. Early acquired syphilis is subdivided into incubation period, primary, secondary, early, latent stages. Early acquired syphilis subdivided into incubation period, primary, secondary, early, latent stages. Late syphilis includes late latent stage, late benign stage, stage of gamma, 3 stages of cardiovascular and neurosyphilis. Late syphilis, 3 stages. Late latent, late benign, and complications, cardiovascular and neurosyphilis. Primary syphilis. First clinical manifestation is local lesion at site of entry. It starts as dull red macule, rapidly becomes papular, and then ulcerate. A small, clean, painless, hard ulcer, Hunterian chancre, small, clean, painless, hard, appears on site. Early chancre has clear red base, but later covers with a gray slough. Untreated chancre will persist for not more than 6 weeks and then heal. Regional lymphadenopathy develop in 1 week and nodes are painless, non-tender, small, to moderate in size, rubbery, and non-suppurative. Secondary syphilis. Tripanoma pallidum disseminate widely throughout body. After 3 to 6 weeks, disease seen to be systemic. The more common symptoms include sore throat, malaise, headache, weight loss, fever, musculoskeletal pains. A rash of early secondary stage appears on back, chest, abdomen, arms, thighs, also on mucus patches in mouth. Rash includes palms, sores. Rashes can be follicular, annular, or papular. Follicular, annular, or papular. Papular rash may be large, raised, and may resemble viral warts, but they are characteristically broad and flat, so-called condylomata lata. Condylomata lata. Generalized lymphadenopathy, common, with moderately enlarged nodes, rubbery, discrete, and non-tender. Even rash may subside with little treatment, but infective relapses occur with varying intervals of latent periods. Latent syphilis. Latent syphilis has no clinical manifestations of Tripanoma infection. Early latent equal infection of less than 2 years, whereas infection more than 2 years late latent. Involvement of other systems occur in 10% of cases or less. After 4 years, benign manifestations as gamma in bones, deeper parts of skin, muscle, or liver appear. After 5 to 10 years, or up to even 20 years, vital organs like brain, heart, nerves, and big arteries affected, and severe signs of cardiovascular and neurosyphilis may appear. Predominant features of cardiac syphilis are aortic regurgitation, aortic aneurysm, arrhythmias, and angina. Neurosyphilis can present in a variety of ways: meningovascular syphilis, tabes dorsalis, and general paresis. Congenital syphilis. It is important. If infection transmitted from mother to child in utero, called congenital syphilis. Prevention of congenital syphilis is visible by effective screening for pregnant women at first prenatal visit. Effective screening in pregnant women at first prenatal visit. If expectant mother is positive for syphilis, so give penicillin during pregnancy will prevent transmission to child. This is important. All infants born to seropositive mother must be treated with single dose of benzyl penicillin, 50,000 international units per kilogram, given intramuscularly, whether or not the mothers were treated during pregnancy with or without penicillin. Such infants should be examined at birth at monthly interval for 3 months. This slide is very important about congenital syphilis. Syphilis and HIV infection. All patients with syphilis should be encouraged to undergo HIV testing due to high frequency of dual infection and its implication for clinical assessment and management. Conventional syphilis treatment often fails in HIV-infected patients. Also, HIV patients have accelerated progression to early neurosyphilis. Due to AIDS epidemic, neurosyphilis becoming more common in young adults. In case of congenital syphilis, mother encouraged to do HIV testing. Recommended treatment for early syphilis in HIV patients is no different. However, careful follow-up is necessary to ensure adequacy of treatment. Diagnosis of syphilis. Diagnosis of primary heart chancre is confirmed by finding Tripanoma pallidum on dark ground examination of discharge from ulcer. In late primary or further stages in congenital infection, it is confirmed by Wassermann-Hahn or VDRL reaction. A skin biopsy may be quite helpful. Other tests are fluorescent antibody absorption test, microheme agglutination assay for antibodies to Tripanoma pallidum, heme agglutination tripanomal test for syphilis. Treatment: early syphilis in HIV negative patients, benzathine penicillin or procaine penicillin for 10 days. Benzethine penicillin or procaine penicillin for 10 days, and here is the dose. In HIV positive patient, procaine penicillin after test given for 14 days, crystalline penicillin for 10 days after test dose. Penicillin allergic non-pregnant patients, doxycycline or tetracycline. Doxycycline or tetracycline 4 times daily for 2 weeks. Penicillin allergic pregnant women, erythromycin 4 times daily for 2 weeks. Treatment continued. Late syphilis in HIV negative patient, benzethine penicillin or procaine penicillin for 21 days. In HIV positive patients, procaine penicillin, crystalline penicillin for 2 weeks. Penicillin allergic non-pregnant patient, doxycycline and tetracycline. Penicillin allergic pregnant patients, erythromycin 30 days. Treatment continued. Neurosyphilis. Recommended regimen, crystalline penicillin for 14 days. Alternative regime, procaine penicillin 4 times daily for 2 weeks. Penicillin allergic non-pregnant patients, doxycycline and tetracycline. Surveillance for syphilis. Post-hospital surveillance must be carried out to ensure radical cure. All clinics should maintain a STD register. The clinic should ensure that person reports on due dates to medical office who should do treatment or send him to hospital, whichever is indicated. Examination and the treatment of his wife and, if necessary, of children should also be arranged. This figure shows the first one on the left, congenital syphilis in a 2-week-old boy with marked hepatosplenomegaly as shown. Neonate kept his upper extremities in a flail-like position due to painful periostitis. The one in the middle, upper extremities of patient in image with early periostitis. This is the child on the left X-ray. Radiolucency of distal radius and ulna bilaterally on both sides. This is a newborn on the right side with congenital syphilis with bleeding from nares and tender swelling of wrists. Very clear. And this is the bleeding. And elbows secondary to aortic periostitis. On the left side, this congenital syphilis with pneumonia alba. The infant survived with penicillin treatment. The one in the middle photograph shows presence of a diffuse stromal haze in cornea of a female patient known as interstitial keratitis. Interstitial keratitis due to her late-stage congenital syphilitic condition. Interstitial keratitis due to inflammation of cornea, connective tissue elements, and usually affects both eyes. Can occur as a complication of congenital or acquired syphilis. Interstitial keratitis usually occurs in children older than 2 years. The one on the right side, condyloma lata, in a 7-year-old girl who was sexually abused. These whitish-gray moist lesions are caused by Tripanoma pallidum and are highly contagious. On the left side, Hutchinson teeth, a late manifestation of congenital syphilis. These teeth. Changes occur in secondary dentition. The central incisors are smaller than normal and have sloping sides. The one in the middle image shows an extensive chancre located on penile shaft with primary syphilitic infection due to Tripanoma pallidum. Primary stage of syphilis is usually marked by appearance of single lesion, called chancre. Chancre is usually firm, round, small, painless. It appears at spot where Tripanoma pallidum entered body, lasts 3 to 6 weeks, healing on its own. This is syphilis with penile chancre on the penis. The one on the left, a 16-year-old girl with rash of secondary syphilis. These rashes. Notice at 3S gestation of her pregnancy. Third trimester. Symptoms and signs of secondary generally occur 6 to 8 weeks after primary infection when primary lesions have usually healed. Secondary syphilis, this is on the right, secondary syphilis in a different patient, it image with discrete palmar lesions. The diagnosis was suspected because of the palmar lesion. This is the foot. This patient presented with a papular rash on the sole of the foot due to secondary syphilis. The second stage syphilis starts when one or more areas of the skin break into rash that appears as rough red or reddish brown spots on palms of hands and bottoms of the feet. Even without treatment, the rash clears up spontaneously. This photo shows an electron photomicrograph of two spiral-shaped Tripanoma pallidum bacteria. Endemic syphilis. Early lesions of endemic syphilis: Bigel, Setae, Shawa, Nojo Vera, Skerligivo are localized primarily to mucocutaneous and mucocutaneous surface. Infection is reported to be transmitted by direct contact, by kissing. This is the way of transmission, not sexual. Direct contact by kissing or sharing, drinking, and eating tonsils. A rule for insects in transmission suggested, but is unproven till now. Initial lesions usually an intraoral papule, often goes unrecognized and is followed by mucus patches on oral mucosa. Mucocutaneous lesions resembling condylomata lata of secondary syphilis. This eruption may last for months or even years, and Tripanoma can readily be demonstrated in early lesions. Periostitis and regional lymphadenopathy are common. After variable period of latency, late manifestations may appear, including osseous and cutaneous gamma, destructive gamma ostitis, and gangosa are more common in endemic syphilis than in late yaws. Penta mal del pento karate azul purpuru is the most benign Tripanoma infections. This disease has 3 stages characterized by marked change in skin color. The figures will come. But Penta does not appear to cause destructive lesions or involve other tissues. The initial papule is most often located on extremities or face and pruritic. After many months of infection, numerous disseminated secondary lesions, pentidis, appear. These lesions are initially red but become deeply pigmented, ultimately turning a dark salate blue. The secondary lesions are infectious and highly pruritic and may persist for years. Late pigmented lesions called dyschromic macules and contain Tripanoma. Over time, most pigmented lesions show varying degrees of depigmentation becoming brown and eventually white, and giving skin a mottled appearance. White achromic lesions are characteristics of the late stage. Treatment of endemic Tripanoma. WHO recommends treat the patient and their contacts benzethine penicillin. This dose is half of that recommended of early venereal syphilis. Definitive evidence of resistance to penicillin is lacking, although relapsing lesions reported after penicillin treatment in Papua New Guinea. These are the figures, clinical manifestations of endemic Tripanoma. Left papillomatous primary lesion of Yaus. Center split papules of early endemic syphilis. Right pigmented macule of Penta. Prevention and control of sexually transmitted disease. Look, sexually transmitted diseases first lecture. And this is a new approach for management of sexually transmitted disease. The traditional approach, the lab-assisted approach, and the syndromic approach. Traditional approach: interview patient for symptoms, does clinical examination, use clinical experience to identify symptoms and signs of a specific disease, treats for the specific disease, educate patients for compliance and prevention, promotes condoms, and emphasizes the importance of partner management. Lab-assisted: interview patient, does clinical examination, collect samples, and test it, treats sexually transmitted infection by results of lab, educate patients also the same. Syndromic approach: interview patient for symptoms, does clinical examination for finding signs, use flowchart as tools, syndrome identification, treat patients for the most common organism responsible for that syndrome, educate patients for compliance and prevention, and other things. What are syndromes for women? Symptoms: vaginal discharge. Syndrome: vaginal discharge syndrome, most probably gonorrhea, chlamydia, trichomona, herpes simplex, candidiasis, bacterial vaginosis, cervicitis. Lower abdominal pain syndrome, gonorrhea, chlamydia, mycoplasma, Gardnerella, anaerobic bacteria type. Genital ulcers, genital ulcer syndrome, syphilis, chancroid, genital herpes, genital warts, molluscum contagiosum, pediculosis, and scape. For men, symptom: urethral discharge, most probably gonorrhea, chlamydia, trichomonas. Genital ulcer, most probably chancroid, syphilis, genital herpes. Inguinal pubis, most probably lymphogranuloma, venereum, chancroid. Scrotal swelling, gonorrhea, chlamydia. Genital skin conditions: genital warts, molluscum contagiosum, pediculosis pubis, and scape. Drug therapy in syndromic approach: urethral discharge, anorectal discharge, cervicitis, azithromycin. Vaginitis: fluconazole or cenidazole. Genital ulcer disease: benzethine penicillin, azithromycin. Genital ulcer disease: doxycycline, azithromycin. Genital ulcer disease: acyclovir. Lower abdominal pain: cefixime, metronidazole, doxycycline. Inguinal pubis: doxycycline, azithromycin. 10 questions for sexually transmitted and HIV risk assessment. Framing statement: in order to provide the best care for you today and understand your risk of certain infections, it is necessary for us to talk about your sexual behavior. Screening questions: do you have any reason to think you might have a sexually transmitted disease? If so, Why? For all adolescents less than 18 years, have you begun having any kind of sex yet? Std history. Have you ever had any sexually transmitted infections or congenital infection? Sexual preference. Have you had sex with men, women, or both? Injection drug use. Have you ever injected yourself? Characteristics of partners. Has your sex partner had any sexually transmitted infection? 8. Has your sex partner had other sex partners? STD symptoms checklist continued. Have you recently developed any of these symptoms? For men, discharge, genital sores. For women, abnormal vaginal discharge, genital sores. Sexual practice past 2 months for patients answering yes to any of the above questions. Now I'd like to ask what parts of your body may have been sexually exposed to sexually transmitted disease. Query about interest in sexually transmitted disease screening test. Do you want to have this test? وفي النهاية أقول الحمد لله رب العالمين و thank you for your good listening.